Hello and welcome to our lecture number 5 in this series on alcohol, alcoholism, and inhalants. So we're going to talk obviously about alcohol, its pharmacokinetic properties and its pharmacodynamic properties, spend a little time talking about alcoholism, a very brief time talking about inhalants. Inhalants are volatile liquids just like alcohol, so that's why they kind of get included in the same group of drugs. This is our first foray into talking about classes of drugs. We spent all of our time thus far talking about pharmacokinetics, pharmacodynamics, brain, and some issues with drug abuse and addiction. So now we're going to spend some time talking about the rest of the semester, talking about specific drugs and issues with those. So we'll start with alcohol. It's obviously the most commonly used intoxicating drug in the United States and worldwide. So we'll talk a little bit about the demographics of alcohol use, talk about what alcohol actually is, talk about its pharmacokinetics, and talk specifically about the effects of caffeine and alcohol together. So we'll do a special note there. Talk about the pharmacodynamics of alcohol, its pharmacological effects, and finish up talking about tolerance and dependence. Then we'll move on to talk about alcoholism and inhalants. So first in the demographics, 14 million Americans have problems with alcohol directly. 7 million people in the United States are alcoholics, so a pretty widespread problem. 10% of the drinkers in the United States drink 50% of the alcohol. So that's a pretty startling statistic. Half the alcohol is drunk by only 10% of drinkers. Most of people who drink, the other 90%, drink moderately, drink safely, have no problem functioning. It is this 10% that we really are focused on when we're talking about direct alcoholics. So when we talk about alcohol, we're talking about, of course, ethanol or ethyl alcohol, which is alcohol that can be drunk. Other alcohols, like isopropyl alcohol, are quite toxic, or methyl alcohol or wood alcohol are all quite toxic. These other alcohols are metabolized to formic acid and formaldehyde, and as a result, you end up with vomiting, blindness, coma, and potentially even death. So ethyl alcohol is the alcohol we can drink. There is a lot of controversy over the United States government's actions during Prohibition because some industrial-grade ethyl alcohols were specifically poisoned with methyl alcohol to try to keep people from drinking them, and they drank it anyway. And as a result, quite a few people were killed, blinded, etc. by this particular action. So there's something to be careful of and cautious of, and make sure that you're obviously getting your alcohol, which is obviously easy to get, but don't go making it at home. So there are 3 major types of drinking alcohol. Beer, which is generally 3 to 6% alcohol, although if you drink microbrews, they can have up to 9%, and some microbrews can even have higher percentages, so keep that in mind if that's what you prefer to drink. Our first recorded brewery was in Egypt around 3700 before the Common Era, so that puts it fairly early in our history. We've been drinking beer a very long time. Not quite as long as wine. Wine is generally around 12% alcohol. Can be fortified to 20% with distilled spirits, and the oldest recorded history of wine goes back to 5400 BCE in Iran. Distilled spirits tend to be around 40 to 60% alcohol. They're normally given a proof rating, which is 2 times the percentage of alcohol, so something that is 100 proof is 50% alcohol. So a liquor like Bacardi 151 you want to be very careful of because it has 75.5% alcohol, so that's something to be very cautious of. Finally, we get the conversion of wine into brandy, and brandy is simply distilled wine that starts to occur during the Middle Ages. And so we have a fairly long history with alcohol, but the earliest record of distillation is then in the Middle Ages. So alcohol is, of course, produced by fermentation. Sugar and water and air is invaded by yeasts. Yeasts then consume the sugar, forming ethanol and carbon dioxide, which bubbles up and escapes, unless, of course, you're brewing beer. Yeast cannot survive in high alcohol concentrations, so the best you can get is at about 10 to 15% in a fermentation. So on their own, yeasts can only produce beer or wine. Everything else is produced through fermentation followed by distillation. So distillation is a process by which we get actual distilled alcohol. So this removes the water and increases the alcohol content. And those of you who may have done this in science class, it's fairly straightforward. You slowly heat the fermented product, and then it gets run through a coil for it to cool down and evaporates. And if you do this at the appropriate temperature, the alcohol will evaporate earliest, and so the early products of that distillation product will be higher in alcohol percentage. So the slower it's distilled, the higher the alcohol percentage. So that's a big part of how this process works. To give you an idea of where these different liquors we drink come from, brandy is a form of distilled wine. Whiskey is from grains, primarily corn, but other grains as well. Rum is distilled with molasses. Schnapps is distilled from potatoes. Tequila is distilled from, or is fermented from blue agave cactus, so that agave nectar you see at the grocery store. That's where that comes from. And then gin and vodka are mixtures of pure alcohol with water and flavoring. And so depending on the kind of vodka you drink, and every vodka is a little bit different. Some vodkas, like Sky vodka, are filtered to a great extent, and as a result, they are formulated, at least in theory, to provide less of a hangover because they've been filtered out more, whereas the cheaper forms of vodka oftentimes have a lot of the crap in them and are much more likely to give you a hangover. At least that's the idea. So what is the typical measurement of an alcohol serving? So a typical serving of an alcoholic beverage should contain about the same amount of alcohol. We all know that that's not necessarily the case, but we want to be mindful of this as we're out trying to be safe consumers of alcohol and think about how this relates to our blood level. So a 5-ounce glass of wine and an ounce and a half of most liquors or a 12-ounce beer are close to the same thing. Now the problem is that's the first step in understanding how much drinking influences your blood alcohol level. So starting by what you're putting in is the first place in this overall equation. So our blood alcohol concentration is expressed in terms of milligrams of alcohol per 100 milliliters or 1 deciliter of whole blood. So it's expressed as a percentage. So 80 milligrams per deciliter is 80%, which she'd be long since dead by then. But just to give you an example, most of the time when we talk about blood alcohol concentrations, we're talking about less than 1%, 1/10 of 1% of alcohol. So 0.1 is pretty intoxicated. So to try to understand how the dosing of alcohol affects your blood alcohol concentration, the first place we have to stop is looking at the absorption. So it's absorbed rapidly from the stomach and small intestines. Alcohol is soluble in both fat and water, so it's absorbed quickly. About 20% is absorbed from the stomach. That percentage is affected by a variety of factors, including the presence of food will slow absorption. Anybody who's drank at all knows this, that if you eat before you go out drinking, you'll have a much better experience because alcohol will be absorbed more slowly. You won't get intoxicated as quickly. Drinking on an empty stomach is always something to try to be avoided. Again, the volume and concentration of a dose is going to also be affected, is also going to affect the absorption. This is why shots are often such a nefarious process when we go out drinking, because they're low volume, high concentration, whereas if you're drinking 20-ounce beer, you're going to drink that more slowly. It's going to have water in with it. If you're drinking a mixed drink, again, it's going to have other liquids in with it. They're going to help, water down the amount of alcohol we're drinking. So if you are drinking something like shots, you always want to have something non-alcoholic, or try to have something non-alcoholic with it, some water, a soda, or even at least, don't be doing shots and liquor drinks, maybe shots and beer. Again, try to be responsible and not end up with that high volume of alcohol. So in the stomach, alcohol is actually an irritant. It increases the flow of hydrochloric acid, and pepsin is one of the reasons why chronic alcoholics have such a problem with ulcers. So 20% of the alcohol that's absorbed comes from the stomach. The rest of it comes from the small intestine. Anything that affects movement to the small intestine might affect absorption. So food, etc. The time from your last drink to maximal absorption in the blood is about 30 to 90 minutes. Again, important to keep in mind. When you're leaving the bar, if you've just had drinks before you leave, you're not as drunk as you're going to be. So that's something to always watch out for. You just want to be cautious about that because it is about 30 to 90 minutes before you get that maximal absorption. So alcohol is evenly distributed throughout the body. It freely crosses the blood-brain barrier. It's freely distributed to a fetus. Fetal blood alcohol concentration is the same as their mother. Concentration in exhaled air versus venous blood is 1 to 2300. This calculation is used for breathalyzer tests, as you see in the photograph. Excuse me. So a couple of important things to understand. The fetal blood alcohol level is going to become very important when we start talking about fetal alcohol syndrome. The CDC in the United States has a firm policy that pregnant mothers should not drink at all. And so that's an important thing to keep in mind. Also, understanding this basis for breathalyzer test is also very important. Now, the problem with this kind of testing is it's based on mathematical modeling, and so most police departments, if you fail a breathalyzer, will then do an actual blood test to get a much more accurate assessment of your blood alcohol level. So, no surprise, alcohol is metabolized entirely by the liver, or almost entirely by the liver. About 95% of what you drink is metabolized by your liver. The other 5% is excreted unchanged from your lungs. So alcohol is a volatile liquid. It evaporates in air. So as it's passing through in your blood through your lungs, it comes out through your breath. Alcohol dehydrogenase is an enzyme that breaks down ethanol to acetaldehyde. The maximum amount that can be metabolized by your body is about 1 drink per hour. This is a really important thing to keep in mind, because if you have 3 drinks all in a row, it will be 3 hours before those are metabolized. If you have 10 in a row, it's another 10 hours. And so understanding this kind of metabolic rate is really important. If you have anything that is slowing down your metabolic rate in your liver, so if you take other prescription drugs, if you drank the night before, all of those have the tendency to affect how fast you can break down alcohol. So 1 drink per hour is as fast as your body can go. And there's always the chance that it's going to be slower. So that acetaldehyde is then broken down into acetic acid and is expressed out that way as carbon dioxide and water. Important thing to understand about the pharmacokinetics of alcohol is there is a huge sex difference in alcohol metabolism. Women have higher blood alcohol concentration for the same number of drinks, even if you adjust for body weight. The first thing you have to understand about blood alcohol concentration is it's a percentage of the amount of blood you have. If you are a bigger person, you have more blood. And so 1 drink is going to get distributed across that body more freely. And obviously, on average, women tend to be smaller and shorter than men. Now, that doesn't account for this issue. Women actually, if you adjust for body weight, still have a higher blood alcohol concentration, and that has to do with relatively lower levels of alcohol dehydrogenase. So women have 50% less gastric metabolism of alcohol, which leads to a 7% increase in blood alcohol content over men. And so this is why you get that kind of 2-to-1 rule about how many drinks men should have versus women, because men are much more efficient processors of alcohol. Again, about at the 50% level is where women are. Men also have a higher muscle-to-fat ratio in general, and more blood flow, so alcohol is often more diluted in men. Women have higher fat content. This doesn't mean that they're fatter, but they have breast tissue and a different distribution of fat on their hips and etc. So overall, and on average, women have higher fat content, which stores little alcohol, which means more alcohol in blood plasma. So someone who has higher muscle ratio will be able to process more alcohol because they have more blood flow. Higher fat content will not help that at all. So to get at this 3-step metabolic process involved in the breakdown of alcohol, alcohol dehydrogenase functions to convert alcohol to acetaldehyde. Nicotinamide adenine dinucleotide is required for activity rate limiting step in reaction, so this is one of the reasons why it's slower. Alcohol dehydrogenase converts acetaldehyde to acetic acid. Acetic acid is then broken down into carbon dioxide and water, and thus releasing energy as calories. So that's one of the reasons why alcohol has a high amount of calories in it, and it's always something to keep in mind. If you look at this occurring in the liver, there are 2 lobes to the liver. Ethanol is primarily or entirely 95%, broken down in the liver. You can see ethanol gets converted into acetaldehyde and then into acetic acid. There are, of course, a great number of individual variations in the elimination of alcohol, so keep in mind that the same number of the same person might eliminate alcohol more quickly. So if we look at blood alcohol elimination in grams percentage per hour, it's down to from 0.01 up to 0.015. So again, that's a pretty dramatic increase. It's a 50% increase in the ability of someone to process out alcohol. And then you have down at the end somebody who's very super rapid at processing out alcohol. So there are some genetic differences. So if we look at how many drinks you might be able to have before driving, the safest thing is none. The only safe legal driving limit is 0. Impairment begins here. If you look at men versus women, you can see they've started the scale a little bit different in body weight. Average male is somewhere in this 160 to 200 pound range. So the lighter you are, the lower your level is. So at 1 drink, impairment begins immediately for someone who's only 100 pounds and they've already reached the legal limit of 0.04 at DWAI, which is driving while ability impaired. At 2 drinks, unless you're over 220 pounds, your driving skills are significantly impaired and you are over the legal limit. Anyone who has more than 4 drinks is certainly way over the limit. And so 1 to 2 drinks is really where you want to hold your limit. And you can see for women, it's far more at 1 to 2 drinks, certainly far more at 1 drink, that they become impaired. Quick note on caffeine and alcohol. It's important to understand that caffeine masks some of the effects of alcohol. As a result of consuming significant amounts of caffeine with alcohol, the caffeine can actually mask how intoxicated you really are, because caffeine is an stimulant and alcohol is primarily a depressant. It has some paradoxical qualities we'll talk about here in a minute with both stimulant and depressant qualities, but caffeine is entirely a stimulant, and so the sleepiness or some of the lightheadedness you might get with alcohol can be masked by consumption of caffeine, especially with large amounts of caffeine like with a Red Bull and vodka. So what's more important is not just that, that the caffeine is masking the alcohol, and so you end up consuming more alcohol than is probably safe. That the two have very different pharmacokinetic profiles. And so while alcohol is metabolized via a steady state, which is shown in the red line here, caffeine is metabolized via a half-life. And that's going to be our next topic of discussion, is caffeine and nicotine. And so what happens, as you can see, is while the alcohol is slowly tapering off in a linear fashion, the caffeine drops out rather rapidly. And so as a result, someone who has had caffeine and alcohol will find themselves suddenly very intoxicated, as you can see at about hour 2 or 3, because that half-life has dropped off so dramatically. And so what happens is, while alcohol is being steadily and slowly eliminated one at a time every hour, that half-life decay causes this dramatic sudden drop in caffeine levels, and as a result, people oftentimes find themselves suddenly very intoxicated. So it's something to be very cautious of and very mindful of. So moving on to talk about pharmacodynamics of alcohol. Alcohol's been a bit of a mystery for some time. For many years, we assumed alcohol was a general depressant for nerve membranes and synapses, working on some sort of general level. There is evidence emerging that alcohol actually disturbs synaptic activity of neurotransmitters, particularly glutamate and GABA. And GABA becomes very important because, of course, GABA is an inhibitory neurotransmitter, and as a result, anything that influences GABA is probably going to interact with alcohol on a pretty significant level. So drugs like benzodiazepines certainly should never be taken along with alcohol. The final thing that alcohol seems to affect is various intracellular transduction processes. So we'll start by looking at how ethanol inhibits responsiveness of NMDA receptors to glutamate. So remember, glutamate's an important neurotransmitter that's then exacerbated by the enhancement of the inhibitory neurotransmitter GABA. So we get inhibition of glutamate receptors, enhancement of GABA transmission, and as a result you get a depressant effect. Acamprosate, which is a structural analog of glutamate, is currently being used to maintain abstinence in some alcohol-dependent patients because it essentially is an antagonist of glutamate. The GABA receptors, ethanol activates GABA-mediated increases in chloride ion flows, and so as a result you get neural inhibition. This results in sedation, muscle relaxation, and importantly, inhibition of cognitive and motor skills, and some anti-anxiety effects of alcohol. It's the reason why people sort of get that alcohol-related courage, which is sometimes excessive of where it should be. This ultimately leads to augmentation of dopaminergic projections from the ventral tegmental area to the nucleus accumbens, right there at that reward circuit. So here's where the rewarding effects of alcohol is. That's the reason why alcohol sometimes feels very good. Unfortunately, ethanol and stress may actually interact. We know that GABA is an important part of our stress response. So GABA-mediated inhibition may actually lead to an activation of opioid receptors, which then influences the behavior rewarding associated with the activation of dopaminergic neurons. So by inhibiting these GABA GABA-mediated inhibition, that inhibition is being caused by GABA, may lead to the activation of opioid receptors, which are, of course, an important part of addiction processes, which influences behavior rewarding, which is associated with the activation of dopaminergic neurons. And so this interaction between the two seems to result in people who are under a great deal of stress being at greater risk for alcoholism. So alcohol also affects the opioid receptors. Alcohol-dependent people may have a genetic dysfunction in the brain's opioid system. We certainly know genetics are an important part of this puzzle. Alcoholism certainly can run in families. And we think that ethanol may trigger an opioid release, and more so in people with this genetic dysfunction, which triggers a dopamine response in the reward circuitry. This is the reason why naltrexone, which is an opioid antagonist, may actually help reduce alcohol craving by reducing activation of the opioid receptors. And then finally, the sigma-1 receptors appear to modulate the effects of alcohol and other drugs of abuse on neurotransmission, gene regulation, and neuroplasticity. So there is a great deal of information to still be learned about how alcohol affects receptors specifically, and in particular the opioid receptors, because there seems to be a lot of work being done to try to understand how alcohol affects neurotransmission, gene regulation, and the plasticity of neural connections. Alcohol also affects serotonin receptors as well as cannabinoid receptors, so it actually has some pretty wide-based effects. Chronic alcohol use augments serotonergic activity, so serotonin dysfunction may play a role in some types of alcoholism. There seems to be an emphasis in the 5-HT2 and 3 receptors, which are located in the dopaminergic neurons right back in the nucleus accumbens. So this is where we get at that rewarding properties of alcohol are in the nucleus accumbens. Serotonin reuptake inhibiting antidepressants like Zoloft seem to be more effective in reducing drinking in lower risk alcohol males. So there is some question as to whether or not people are at slight risk for excessive drinking. Something like a serotonin reuptake inhibitor might reduce the probability that they become problematic drinkers. Now, the question of whether or not that's effective for all males is, of course, something to wonder about. The cannabinoid receptors are also affected by alcohol. Chronic alcohol use stimulates formation of endogenous cannabinoid transmitter anandamide. This leads to downregulation of cannabinoid receptors, thereby disinhibiting the nucleus accumbens. Cessation of drinking then causes a hyperactive endocannabinoid reaction, which results in alcohol craving. And ethanol and cannabinoid agonists activate the same reward system. So if we're talking about marijuana and alcohol, they activate the similar parts of the reward system. So ceasing drinking can result in craving. We'll also talk a little bit about how chronic alcohol abuse, with the withdrawal effects associated with that, can be pretty severe. So the next spot to focus on in terms of our understanding of alcohol is to think about its pharmacological effects. So what are the ultimate effects of how alcohol influences us? Certainly we get respiratory stimulation at low doses, but respiratory depression at high doses. High doses of alcohol can be potentially lethal because of that depression and respiration. Alcohol is an anticonvulsant, and withdrawal can result in seizures. Alcohol affects blood circulation. It causes dilation of blood vessels in the skin. So your skin will feel warm, people will feel hot, but you're actually colder because you're putting off so much more heat. In small amounts, less than 2 drinks per day, you actually can lower your risk of heart disease and ischemic stroke. More than 14 drinks per week, however, increases the risk of stroke, and binge drinking is certainly a big part of this. So it's not that you can have all 14 of your drinks on one day. It's 2 drinks per day or less seems to have an effect on your risk of heart attack, and that's because alcohol does thin your blood a bit. Sleep is another problem with alcohol. Alcohol can induce sleep, but it will suppress rapid eye movement or REM sleep. REM sleep is very important for us to actually wake up feeling refreshed, and it has some very important neural implications. As a result, if you've been drinking alcohol and you've been in suppressed REM sleep, you'll actually experience what's called REM rebound. And finally, and very annoyingly, alcohol may cause early awakening when you probably really feel like sleeping the most. Other psychological effects include, of course, intoxication. At low doses, this is largely determined by the person, what we call set and setting. Can be from relaxed to euphoric to withdrawn and violent. So both the person and their setting can really influence the kind of behavior or psychological effects of alcohol. Your mental expectations are less important as dosage increases. The dosage starts to overwhelm whatever your mental expectations are, and you become progressively incapacitated as blood alcohol content increases. You start to get blackouts at around 0.25 blood alcohol content, and then you start getting into um, stupor, passing out, sleeping, and death up there at around point 0.4. Those are very, very high blood alcohol concentrations. Anything beyond like 0.12 is really, really intoxicated. And so you always really want to keep in mind, keep yourself safe. And obviously, if you are anywhere over the 0.04 level, catch yourself an Uber or a Lyft or a cab or some way to get home that doesn't involve driving. Alcohol's disinhibition effects certainly plays a role in a variety of crimes. Alcohol is implicated in over 50% of homicides and assaults. Over 40% of violent offenders in prison were drinking at the time of their offense. You often get what's called alcohol myopia, which are cognitive and attentional deficits, which causes a focus on the present, which reduces fear and anxiety because there's no worry about the future, and certainly impairs problem solving. People will do very dumb things when they are drunk, as I'm sure you well know. You also get increased concerns with power and dominance, and seems to be linked to male violence and domestic conflict. There seems to be, again, this disinhibition removes some of the control rods from aggressive tendencies, and people fly off the handle and become very aggressive, or can, depending on their personality. Of course, we know that people who regularly ingest alcohol develop tolerance. It's a well-known, well-established phenomenon that most of us are familiar with. There are 3 different types of tolerance. Metabolic tolerance, where the liver increases drug metabolizing enzymes. This accounts for about 25% of our tolerance at most. We get tissue, or what we call functional tolerance, so neurons adapt to drugs' presence. So it's simply that your neurons have gotten used to there being alcohol around, and so these neurons that have adapted to drug presence, the blood alcohol concentration can be double that of non-tolerant drinkers and be at the same level of behavioral intoxication. This is behavioral only, not tolerant to memory or cognitive effects, so people who have this level of tolerance probably black out quite a bit. That is, they have no memory of what happened. And then finally, associative tolerance. This is related to environment. And so sometimes the situation we're in can lead us to being able to drink more. And if you're out, really having a good time and dancing and doing all sorts of other things that are positive. So dependence on alcohol occurs after long-term chronic use, or can happen over a period of shorter periods of time if you've had a pretty strong bender. So you can end up with alcohol withdrawal if you have significant alcohol intake. This can develop in several hours and can be very severe. A common cause of adult onset seizures is alcohol withdrawal. This occurs in 10% of adults during alcohol withdrawal. This is most likely to occur in someone who is a chronic alcohol user. Detoxification of alcoholics during this period involves blocking or preventing seizures. Usually this is done with benzodiazepines or anticonvulsants. There is a kindling model that believes that, or that shows that repeated alcohol withdrawal leads to an increase in the severity and greater likelihood of seizures. So the more someone goes through this alcohol withdrawal period, the more likely they are to end up with and have more severe forms of seizures. The sort of worst of this is what's called delirium tremens, or the DTs. This is a withdrawal syndrome involving tremulousness, or tremors, hallucinations, psychomotor agitation, confusion, and sleep disorders. And so oftentimes people who are going through alcohol rehab are sedated for a period of time to get them through this withdrawal period. Side effects and toxicity of alcohol. There is reversible drug-induced dementia, that is AKA drunkenness. We call it drug-induced dementia. It's reversed once you sober up. Of course, you can get liver damage. Ethanol produces oxidants when metabolized by the hepatocytes and causes stress on liver cells, and so you can end up with cirrhosis of the liver. So 75% of all alcoholism attributed deaths are due to cirrhosis of the liver. And this causes a wide variety of other problems as well. My father actually had a liver transplant because he had severe cirrhosis of the liver. And as a result, he had a number of problems. His blood pH would get off, and he would um, suddenly not know where he was or even who he was at some point. He would get this global amnesia. He also had co-occurrent with that some eye trouble, including macular degeneration. And once he got his new liver was able to clean up his blood enough that he actually could see better. And so this is a really severe problem. So this is the seventh most common cause of death in America. There is some digestive system damage, which can include pancreatitis, chronic gastritis. Pancreatitis, I can tell you, is quite painful. I've had some friends who have gone through that. And of course, you also get some destruction of nerve cells, particularly what we call alcohol-related dementia, which is usually called Korsakoff syndrome. And we're going to talk a little bit more about that when we talk about alcoholism and alcohol abuse here in just a moment. So that's what we'll turn to next, is talk about alcoholism and alcohol abuse. Obviously, this is a significant societal problem. Getting less severe as the years go by. We see less severe forms of alcohol abuse compared to the previous centuries. Lower percentages of adults report drinking at all, and we certainly have much lower incidence of severe alcoholism than we used to. Now, it is still a significant problem, so let's be sure of that. So some of the consequences of alcohol abuse include what I was just mentioning, which is called Korsakoff syndrome. And Korsakoff syndrome is caused by a variety of brain issues, but primarily due to damage to the frontal lobe. You can also get a permanent amnesia due to damage to what are called the mammillary bodies in the brain, where you get no new memories or learning, but relatively normal IQ. You can get some confabulation, which this may improve or even recover with thiamine replacement. The cause of Korsakoff syndrome seems to be due to thiamine deficiency because of the liver damage, so it's secondary to liver damage. Thiamine, or vitamin B, is something that's important for us all to have. In fact, oftentimes some of us don't get enough of it, so it's certainly worth considering a vitamin B supplement, or certainly after a heavy night of drinking, a vitamin B supplement will oftentimes help you with your hangover recovery pretty quickly. More seriously is the problem of fetal alcohol syndrome. This occurs in the offsprings of mothers who have a high blood alcohol concentration during critical stages of fetal development. This occurs at a rate of about 3 to 500 per 1,000 live births. 30 to 50% of alcoholic mothers. About 2.6 million infants in the U.S. are born annually with FAS. Features of FAS include central nervous system dysfunction, pretty severe developmental disabilities, reduced brain size, and some behavioral abnormalities that are akin to attention deficit hyperactivity disorder. So what happens in these kids is they have a lot of conduct disorder, and so it presents similar to ADHD, inability to sit still, but often also goes a little bit further, outbursts, inability to bond with their caregivers, that sort of thing. So they tend to have a slower, retarded both body growth rate, and oftentimes have facial abnormalities. And this is really one of the hallmarks of fetal alcohol syndrome, and we'll show you a picture here in a second about what this looks like. And then the final most severe feature of this is possible congenital heart defects. So FAS has some pretty severe issues associated with it. So this is the facial features you can see with a fetal alcohol syndrome child. They tend to have a flat midface, very somewhat minor ear abnormalities, thin upper lip. They just tend to have this kind of facial feature. The brain of a baby born with severe fetal alcohol syndrome, as you can see on the right, is pretty severely deformed relative to the brain of a normal baby. So obviously that's a severe consequence, and in fact the current recommendation is that pregnant mothers do not drink at all during pregnancy. Certainly no more than a single glass of wine at any given time is where you would want to draw the line. So, alcoholism is a primary chronic disease with genetic, psychosocial, and environmental factors influencing its development and manifestation. This disease is often progressive and fatal. It is characterized by impaired control over drinking, preoccupation with the drug alcohol, use of alcohol despite adverse consequences, and distortions in thinking, most notably denial. Each of these symptoms may be continuous or periodic. So when we're talking about alcoholism, and we're going to turn to talking about alcoholism as a disease model next, we're talking about a chronic disease that has a variety of etiologies, including some genetic, some environmental, and including things like high stress, socioeconomic status. All of these things can contribute to alcoholism. Social support or lack of social support certainly is a big part of that. The biggest hallmarks of alcoholism is this impaired control over drinking. There is an inability to not drink. That is, they're just simply preoccupied with the drug alcohol. They'll use alcohol over all other things despite these adverse consequences and distortions in thinking. And again, most notably, denial. So, obviously, alcoholism is something that receives a lot of attention. It's something most of us have some familiarity with. I want to start by talking a little bit about the history of alcoholism as a disease. In 1935, Alcoholics Anonymous was founded on this moral model of alcoholism. AA offered a spiritual and behavioral framework for understanding, accepting, and recovering from alcoholism. And this model still prevails for some. AA has certainly provided help that a number of people need. Unfortunately, there is little research trying to compare AA to other potentially more helpful models. And it's one of the biggest problems with AA. Again, it has helped a number of people, and I would never deny that someone should go if that's what they feel helps them. But there may be better treatment modalities out there, and that's one of the things we really need to look at is the best way, best evidence-based practices that we can use to try to treat alcoholics. So in 1946, we get a propose of a modern disease concept where we define alcoholism as any use of beverage alcohol that causes damage to the individual drinker, to society, or both. Now this is obviously a rather broad definition and probably overly broad, because someone can cause damage to themselves after one night of drinking that just goes awry, where they don't get somebody to drive them home and they drive themselves and get into an accident, all sorts of things. So I think this is an overly broad definition. From a modern perspective, we focus on this idea of it's disrupting their lives, they're unable to control themselves, etc. So in 1957, the American Medical Association defined alcoholism as a disease. By the mid-1970s, alcoholism was redefined as a chronic, progressive, and potentially fatal disease. Certainly many people die from alcoholism. In 1992, the description again was expanded to include genetic, psychosocial, and environmental factors. And then finally, we get a behavioral model that drinking is a learned but maladaptive behavior. And I think it's all of these things. It is certainly a chronic, progressive, and potentially fatal disease. It certainly has these genetic, psychosocial, and environmental factors, and I think it certainly can be a learned, maladaptive behavior. Another important thing to consider, and we're going to discuss this in a variety of cases when we talk about drug abuse, is this idea of self-medication, where drinking is a means of self-medicating for psychological distress. And I think this is certainly a big part of some chronic drinking behaviors, and even some social drinking behaviors. Sometimes you just have a bad day, and a couple of drinks just takes the edge off. And I think as long as it's on occasion and not a coping mechanism, I don't think there's really that much harm in it. But we're going to talk about self-medication with other drugs. So for example, some ADHD kids might end up abusing methamphetamines because it allows them to concentrate and allows them to feel somewhat more normal. And so we'll talk about this idea of self-medication in a variety of contexts. But certainly with alcohol, it's certainly entirely possible that people who use and abuse alcohol do so as a way to deal with stress because they don't have another healthier way to do so. So exercise or some other healthier method of coping, and so people use it as a coping mechanism. We know that there is a potential genetic contribution to alcoholism. The disorder occurs in all classes of society and walks of life, but you can breed animals that respond differently to alcohol, so it's clearly something that may be inherited. We know, for example, that taste preference for alcohol is inherited, and so some people may just not like the taste of alcohol and others do. And so that's kind of where it starts, is this genetic taste preference. Taste is a really interesting part of our genetics, and so, for example, we know that many people can't stand the taste of cilantro. I'm one of them, and that's due to genetics, because to us cilantro tastes like soap, and that's due to this specific genetic change. Similarly, there seems to be a genetic contribution to taste preference for alcohol. So alcoholism runs in families. Children of alcoholics have a much greater risk for alcoholism, particularly males. Now, the problem, of course, is people who grow up in an alcoholic family have a different environment, and so we have to tease some of that out. So the normal prevalence of male alcoholics is about 3 to 5%. If they're children of alcoholics, it's 20 to 50%. 1% for 0.1% is the normal prevalence for females versus about 3 to 8% if they grow up in a family of alcoholics. So there is certainly something to sex-linked characteristics, whether it has to do with just basic biology, circulating hormones, neurochemistry, or some difference in the Y and X chromosomes. This is a mystery that's still unfolding. Alcoholism has a great deal of comorbidity, which means it's just simply a co-occurs with other problems and disorders or other drug abuse. So much alcoholism may be associated with other psychopathology. About 30 to 50% of alcoholics meet the criteria for major depression. Again, there's a chicken and egg problem. The alcoholism caused the depression, or the depression caused the alcoholism. About 33% may have a coexisting anxiety disorder. This is where I think we're clearly talking about some sort of self-medication where they have anxiety, and the alcohol relieves that anxiety sufficiently so that they can function better without it, or with alcohol, sorry. 38% have some sort of impulse control problem. Again, no surprise. One of the cornerstones of alcoholism is they can't control the impulse to drink. And so this kind of dual diagnosis, some sort of comorbid illness, really is kind of usually presumed until proven otherwise. Because if you add all of this up, we're almost guaranteed that most alcoholics will have some sort of comorbid illness. So how do we treat alcoholism? Well, this is, again, an area where there's lots of work being done. The ideal goals for some sort of pharmacotherapy for alcohol abuse and dependence would be reversal of the acute pharmacological effects of alcohol. So I start there. Treatment and prevention of withdrawal symptoms and complications. And then we want to maintain abstinence and prevent relapse. And then finally, treat coexisting psychiatric disorders and limit neuronal injury during detoxification by blocking withdrawal-induced glutamatergic activation and glutamate receptor upregulation. So one of the things that happens during detox is some pretty significant loss of neurons due to that withdrawal-induced glutamatergic activation and glutamate receptor upregulation. So we have all of these things we want to think about as our goals. And so we'll kind of take a look at how current treatments address some of these issues and where we need some work. So we will start by talking about that as of yet, no agent can reverse the acute pharmacological effects of alcohol. So it's not like with naloxone, which completely reverses the acute effects of heroin, or flumazenil completely reverses the acute effects of benzodiazepines. So currently, we have pharmacotherapies that are available for the following: to treat and prevent withdrawal symptoms, to reduce relapse to drinking behavior. So to treat and prevent withdrawal symptoms, we usually give benzodiazepines. To reduce relapse to drinking behaviors, oftentimes antabuse or naltrexone, which is a different drug, can be given. Treating complications in alcohol-dependent people who are decreasing or discontinuing alcohol use. Again, something like naltrexone would work there. And then to reduce the release and glutamate receptor upregulation, which is reducing subsequent neuronal damage. So here's what we use for management of alcohol withdrawal. Benzodiazepines increase GABA activity, ameliorate the withdrawal symptoms, prevents seizures and the delirium tremens. These long-acting benzodiazepines prevent withdrawal symptoms, and then they're either maintained or slowly withdrawn, allowing the person to function. Drawbacks here are, of course, these are sedatives, and so they sedate people. They end up with psychomotor deficits. They get additive interactions with alcohol, and of course, there is the potential for abuse and dependence on these drugs, and so we don't want to move somebody from alcohol to Klonopin and then have them addicted to Klonopin instead. And so you have to be very careful with this kind of drug activity. Anticonvulsant mood stabilizers can be used for withdrawal. There are fewer limitations than benzodiazepines, but they tend to have a lot of side effects, in particular liver and pancreatic problems. So these are things like Tegretol, Depakote. Newer anticonvulsants seem to be less toxic and have some significant potential. These include Neurontin and Trileptal. We're going to talk about these drugs later on when we talk about bipolar disorder. So some pharmacotherapies to help maintain abstinence and prevent relapse include alcohol sensitizing drugs. So Antabuse or disulfiram produces an adverse reaction if the patient drinks. Opioid antagonists like naltrexone block the reinforcing properties of alcohol, and so by blocking the opioid system, you reduce craving by reducing associated positive reinforcement. And the problem here is compliance. So people lose that reinforcement, that reward, and as a result they just stop taking the naltrexone and go right back to drinking. Acamprosate, or Camprol, is the first pharmacological agent designed to maintain abstinence in alcoholics after detoxification. It's both GABA agonistic and NMDA inhibitory, so it's kind of similar to alcohol. So it's a GABA agonist, much like a benzodiazepine, but it's also inhibitory of the NMDA receptor, much like alcohol. It's comparably effective to naltrexone. The combination of both drugs may be additively effective, so if you put those together, you can see that top dotted line shows the best outcome at 80 days. We're still talking only at about half of patients, but compared to the less than 10% of patients receiving placebo, it's certainly worth a shot. So some pharmacotherapies to help maintain abstinence and prevent relapse are some dopaminergic drugs to try to kind of overcome that loss of reward, so drugs like bupropion or Wellbutrin. They have a theoretical use that both positive reward and withdrawal seem to involve the dopaminergic system. Other drugs or other areas of interest for investigation are serotonergic drugs, possibly nicotinic mechanisms, cannabinoid mechanisms. All of these are areas in which people are trying to look at different pharmacotherapies. So lots of work to be done here. I think the most significant work to be done in these areas is going to involve looking at pharmacogenetics and designing treatments based on someone's genetic composition. So the final thing to talk about in this section of our discussion of drugs and human behavior is to talk a little bit about inhalants. And they're included here because they're volatile gases as well. So what are they? They're this sort of heterogeneous group of central nervous depressants that are volatile at room temperature. So a volatile liquid is anything that is vaporized from liquid when it's exposed to air. So we have things like nitroglycerin, amyl nitrate, and butyl nitrate, which are often called poppers, and were used quite a bit in the disco scene of the 1970s. Anesthetics can include ether, halothane, nitrous oxide. Halothane's a central nervous system anesthetic used as an inhaled anesthetic in surgery. Ether is used to be used. It's sort of the older of the anesthetics. You might have seen film of patients with a paper mask where ether is being poured onto the mask for them to breathe in. And then nitrous oxide, of course, sometimes people get at the dentist. People also inhale solvents like toluene and butane. These are volatile organic solvents like glue, gasoline, paint thinner, not things that are good for you. And then finally, other aerosols, which include halogenated hydrocarbons, hairspray, typewriter correction fluid. All of this really demonstrates to me that if somebody wants to get high, they're going to get high. So what do inhalants do? They can cause permanent brain damage and memory loss. Oftentimes that's due to the fact that the person is oxygen deprived. They can suffer hearing loss, nosebleeds and loss of smell, slurred speech. They can suffocate because they don't have oxygen. You can get irregular heartbeat and heart attack, nausea and vomiting, liver damage, kidney damage, abdominal pain. These are toxins for the most part, particularly things like toluenes and whatnot. They are very toxic to our bodies. And so why do people abuse them? Well, the most common age of abuse are kids, 12 to 17. In the U.S., prevalence among adolescents is exceeded only by alcohol, tobacco, and marijuana. Unfortunately, injuries are often associated with very first use. Even death can occur in first-time users. 70% of deaths due to inhalants are 22 or younger, primarily male, and 46% of fatalities were from gasoline fuels. So if you look at the age here, this spikes at around 12 to 16, and then a little bit of increase there at 20, 21, and then just sort of other spots here and there. The acute effects of inhalants include intoxication, disorientation, impaired judgment, hallucinations, and ataxia, which is loss of motor coordination. Only lasts a few minutes, which then leads to repeated use over several hours. They can be very dangerous, again, due to loss of oxygen and potential organ toxicity. Hypoxia is a really significant problem with inhalants because that loss of oxygen to the brain can result in brain damage very quickly. Chronic effects of inhalants include peripheral and central nervous system dysfunction, liver and kidney failure, dementia, loss of cognitive functions, loss of coordination. They seem to have an affinity for things like the basal ganglia and the cerebellum. In study with normal participants, cocaine abusers and inhalant abusers scored the lowest in working memory, planning, and problem solving. And so that's certainly something we want to avoid. Almost 50% of inhalant abusers had brain abnormalities in an MRI, compared with 25% of cocaine abusers. Treatment for inhalants, usually acute inhalation, is primarily treated with supplemental oxygen. Chronic users tend to resist treatment. Prevention is the best treatment. Keeping people from starting inhalants is the best thing to do. Unfortunately, I can't give you the pharmacokinetics and pharmacodynamics of inhalants because there are so many different kinds of them. We do know that nitric oxide, for example, has specific receptors in the brain, but the effects of all the rest of these are so myriad that it's impossible to try to get one specific discussion of this going. But these really can be dangerous, and you really have to watch out for abuse in kids in particular. All right, well, that's going to be the end of our discussion of alcohol, alcoholism, and inhalants. We'll be revisiting next time with caffeine and nicotine.